طيب بسم الله الرحمن الرحيم. كيف حالكم؟ إن شاء الله طيبين. عندنا هذه ثالث محاضرة في الكلينيكال نيورولوجي سمر كورس بعنوان Approach to Headache and Different Causes. حتقدم لنا إياها الدكتورة أمل إسماعيل، طبيبة مقيمة في تخصص المخ والأعصاب بجامعة الملك عبد الله الطبي في جدة. برضو ننوه إنه إذا عندكم أسئلة حنرسل لكم رابط في الشات نهاية المحاضرة تكتب فيه أسئلتكم ونجاوبكم عليها في القناة. وبرضه كمان حنرسل رابط للتحضير عشان تحضروا نفسكم نهاية السيشن. تفضل يا دكتور.
Okay, I guess we can start now. Good evening, everyone. Hope you're having a pretty nice day, and thank you so much for introducing me. So in this session, we'll be going through the approach to headaches. Hope it would be of great benefit to you. Okay, so here are our objectives. First, we're going to start off with some definition and epidemiology of the headache. Then we're going to go through the overview of headache types, learn the red flags and indications for further investigations, and how to approach a patient with a headache, discuss some differentials, and then some summary and management. So for some definition, the parenchyma of the brain itself doesn't have any pain receptors. So generally, other structures of the head that are innervated are going to be causing headache when they're subjected to any inflammation, any irritation, or any stretching. So these structures include the blood vessels, the meninges, the scalp. Epidemiology-wise, according to the World Health Organization, the prevalence among adults with current headache disorder has been estimated to be around 47%. So half to three-quarters of the adults aged from 18 to 65 years in the world have had a headache in the last year. And among those individuals, more than 10% have reported migraine. So meninges mainly get their sensory innervation by meningeal branch of the trigeminal and vagus nerve. So the anterior cranial fossa and the posterior, we have the ophthalmic division supplying the ophthalmic division of the trigeminal nerve. And for the posterior cranial fossa and the infratentorial dura, both receive supply from the upper third cervical nerves, but to a lesser extent. As for the middle cranial fossa, it is supplied by the maxillary division of the trigeminal nerve. So moving on to the classification, here we have the International Classification of Headache Disorders. They mainly divide headaches to three major categories with sub and sub-subdivisions. So we're not going to go thoroughly through this, but we mainly have the primary, secondary, and finally painful cranial neuropathies and other facial pains and other headaches. For the primary headaches, they're more of a benign intrinsic process. They definitely tend to affect the patient quality of life, but they wouldn't be life-threatening as some of the secondary headaches can be. So in this category, we have migraines, tension headaches, and trigeminal autonomic cephalgias, commonly known as the cluster headaches. So there are others that are way less common, like primary cough headache, hypnic headaches. Okay, so for the secondary headaches, they could be attributed to trauma, to any infection or vascular injury, or, for example, substance use or withdrawal. For the last class, we have the painful cranial neuropathy and other facial pains. Common in this category, we have the trigeminal neuralgia. So this is just one of the approaches you could follow just for simplification. Okay, or you just can use whatever like nice mnemonic you can have. But we can divide here the headaches into just primary and secondary could be further divided into intracranial and extracranial. For the extracranial, we're mainly, so we have the medications or referred pain from sinusitis or dental pain, for example, any eye problems like acute angle glaucoma. So intracranial, we can have vascular etiologies, for example, hypertension that leads to acute hypertensive crisis or PRES. also stroke or CVT. We have also carotid dissection commonly causing headache as a presentation. And also, apart from the vascular, we have infectious. So we have meningitis or meningoencephalitis that can present with headache, along with, of course, fever and neck stiffness. Also, we have in this category abscess or toxoplasmosis as an opportunistic infection in people who are immunosuppressed. Also, we have tumors that can be primary or more commonly metastatic, and any CSF abnormalities causing hydrocephalus, so increased intracranial pressure, and pseudotumor cerebri that is commonly known as idiopathic increased intracranial hypertension. Also, low CSF can cause headache. And other etiologies like trigeminal neuralgia or post-traumatic. So approaching headache, it's very crucial to look for red flags in patients presenting with headaches. Those are worrisome features that indicate more serious underlying causes of headache. Commonly used mnemonic is SNOO. So the S stands for systemic symptoms, signs or diseases, like the B symptoms, fever, weight loss, night sweats. These suggest like an infection process like meningitis, meningoencephalitis, or more of like an abscess as well, or even underlying malignancy leading to brain metastasis, for example, and like other systemic illness, rendering the patient immunosuppressed, for example, HIV, or like patients taking immunosuppressant medications like post-transplant, because you'd also want to be cautious with those patients because of the risk of opportunistic infections. Also pregnancy, as it is considered a hypercoagulable state. So they're more prone of getting thrombosis, CVTs, or they're also at risk of many other complications, including eclampsia, for example. Then we have the N, stands for neurological symptoms and signs. So confusions or loss of consciousness, of course, should not be taken lightly. They could indicate more serious conditions like, for example, meningoencephalitis, stroke, CVT. Also, we have diplopia, pulsatile tinnitus that can result from increased intracranial pressure. So just a couple of examples that could have diplopia as a presentation along with headaches. There is abducens nerve palsy, which can be considered as non-localizing signs. So usually in situations where we have increased intracranial pressure, there might be some downward displacement of the brainstem compressing the cranial nerve, causing a abducens nerve palsy. Also could be as a result of third cranial nerve compression and subarachnoid hemorrhage, specifically from a posterior communicating artery aneurysm rupture. Okay, so then we have the sudden onset headaches that are abrupt, for example, thunderclap headache. Detail the thunderclap headaches differentials in the next slide. So also we have the older age of onset, and we mean by that patients who are older than 50. So usually the more benign, let's say, for example, the common primary headaches have younger age of onset. So even though they could potentially present in the older age group, you still have to eliminate the possibility of secondary headaches. Also, then we have the 4 Ps. First, for pattern change. And so any change in frequency, severity, or clinical features of an already existing headache disorder should prompt for further investigation. We also have headaches precipitated by Valsalva, as these can occur with patients with intracranial hypertension also. Also positional headaches. So we have for example, orthostatic headaches that could occur with intracranial hypotension. And as we mentioned, patients who are pregnant or in the postpartum period should also be taking their headaches seriously. So what are thunderclap headaches? They are headaches of very intense pain that have a sudden onset that reaches its maximum severity or intensity within seconds, so less than one minute. Okay, so people usually relate this to subarachnoid hemorrhage since it's one of the commonest causes of thunderclap headaches. But there are also more conditions that can cause this. But first, we're going to start with the subarachnoid hemorrhage. The etiology of this type of hemorrhage could be divided to traumatic or spontaneous, or to also aneurysmal or non-aneurysmal causes, like or other vascular disorders like AV malformations or sympathomimetic drugs. So beside the thunderclap headaches, they generally also present with some nausea, vomiting, or brief loss of consciousness. They could also have some neck stiffness and meningismus as a result of the blood traveling down through the fourth ventricle into the spinal cord, also causing neck pain. So seizures usually happen in 10% or less of patients during the first day. And so seizures also are a common predictor of poor outcome. Patients also with subarachnoid hemorrhage can experience what's called a sentinel headache that occurs days to weeks before the aneurysmal rupture. So it's a similar character of the thunderclap headache that comes with the subarachnoid hemorrhage, except for that other symptoms and signs aren't usually present, and it's thought to be a result of leaky aneurysm or some changes of the wall of the aneurysm itself. As for the diagnosis, so you're going to have to go ahead and do the head CT without contrast, and if the imaging weren't sufficient and you still have a high suspicion for the subarachnoid hemorrhage, you should go ahead and proceed with lumbar puncture if there's no contraindications. Okay, and then moving on to one of the other commonest causes of the thunderclap headaches, we have the reversible cerebral vasoconstriction syndrome. So as the name suggests, this is a reversible condition of narrowing of the cerebral vessels that is usually multifocal, and it's associated with vasoconstrictive drugs like pseudoephedrine or recreational drugs, also pregnancy, migraine, some miscellaneous causes like hypercalcemia. Okay. So up to 3/4 will only report headaches, but they can also have some nausea, vomiting, and photosensitivity. This also could present with focal neurological deficits as a result of a concomitant stroke or brain edema caused by this condition. So then we have the cerebral venous thrombosis. So just a little more of cerebrovenous thrombosis. Women are 3 times more likely to get this compared to men. And like any thrombosis risk factors and causes, they could be divided into hereditary and acquired conditions predisposing to the cerebrovenous thrombosis. So for the hereditary prothrombotic conditions, we have, for example, the factor V Leiden mutation, protein C or S deficiency, and antithrombin deficiency. And for the acquired ones, these include pregnancy, OCPUs, or antiphospholipid syndrome, also malignancy. So the cerebral veins or the dural sinuses thrombosis are going to block the drainage of the blood from the brain tissue. So it's going to result in high venous and capillary pressure, leading to reduced CSF absorption and increased also intracranial pressure. So in this condition, only around 1/3 of patients will report an isolated headache. So they usually present with other symptoms as well, depending on the vein territory affected. So we can group symptoms into 4 different entities. So they can have headaches and other signs and symptoms of intracranial hypertension. They can have the focal neurological symptoms and seizures, or diffuse encephalopathy and coma. So this is usually occurs with like affection of the deep cerebral venous system, leading to thalamic edema and the reticular activating system impairment. which are the structures largely responsible for consciousness. So patient can also have a cranial neuropathies, for example, if we have the cavernous sinus thrombosis. So the initial imaging for diagnosis, it would be a non-contrast head CT along with the CT venogram, and treatment would be with anticoagulation, even in the setting of concomitant hemorrhage. Then we have cervical artery dissection. This is one of the common causes of stroke in the young. And we mean by that, like people aged 45 or less. So presentation depends on the location of the dissection, but they frequently complain of headache or neck pain. Okay. Then moving on to spontaneous intracranial hypertension. This is caused by a tear in the dura or spinal meningeal abnormalities that lead to the CSF leak into the dural space. Headaches usually are exacerbated by sitting upright, and they improve by lying flat, just like post-LP headaches. So if we do MRI for these patients, we're going to see meningeal enhancement. And of course, when we proceed with the LP, there's going to be a low opening pressure. Okay, and then one other condition is acute hypertensive crisis. They could present with thunderclap headache or other manifestations of hypertensive crisis like chest involvement. So they can also have some dyspnea, chest pain, dizziness. Okay, and then we have less commonly as a presentation of the thunderclap headache, but we have the pituitary apoplexy. So patients with a background of pituitary adenoma can progress to have pituitary apoplexy, which is a hemorrhagic or infarct. Okay, so we're gonna carry on from where the recording stopped. I believe we reached the pituitary apoplexy. Okay, so for the, we're gonna carry on with the causes of thunderclap headaches. We have here pituitary apoplexy. So patients with the background of pituitary adenoma could progress to have what's called pituitary apoplexy, which is a hemorrhage or infarction of a pre-existing adenoma, or even in less common cases, normoglands. So clinical presentations could range from mild to more severe forms caused by the necrosis of the gland. So features other than the headache include chiasmal visual field defects, oculomotor nerve palsies. Okay, then we have colloid cysts of the third ventricle. So colloid cysts are basically a non-malignant mucin-filled lesions, commonly incidentally found in the third ventricle or to a lesser extent in the lateral ventricles, even though they're benign. The problem with these that they might cause obstruction in the ventricular system, leading to acute increase in the intracranial pressure. They could cause transient loss of consciousness or what's called drop attacks. So as for the giant cell arteritis, we're going to discuss it in more detail in a bit. Okay, so one of the causes of secondary headaches are medication overuse headaches. So we're going to start simple with these. They're the most common secondary headaches, and we usually see this in patients with a previously diagnosed headache disorder that are taking their acute or abortive treatments on 15 or more days per month. So management, so typical treatment involves weaning the patient off the overused acute headaches, acute headache medication, while simultaneously focusing on the prophylactic management. Okay, then we have idiopathic intracranial hypertension. So what is IH? It's a disorder of increased intracranial pressure without the presence of any obvious obstructions or reason that could explain the high ICP.
So in the setting of a normal imaging and CSF analysis or other evaluations, so the common population affected are very distinct, which are obese women in the childbearing age, specifically between the ages of 15 and 44. But to a lesser extent, it can also, of course, occur in males in different age groups. So the exact pathogenesis for this disorder is still not really clear, but there is a couple of theories that suggest the presence of impeded venous outflow due to venous hypertension or stenosis. Also, some say that this could be the result of IH and not the actual primary phenomenon. There also may be inefficient CSF absorption. So risk factors include weight gain, of course, and medications like tetracyclines. So patients could be taking those for acne or any other cause. Also growth hormone, which tend to be dose dependent. Okay, so we have also hypervitaminosis A, that this could result from excessive dietary intake or treatment with vitamin A for whatever reason. For example, the retinoid used for dermatological conditions. So it's very important to take careful and detailed medication history. So almost all patients will complain of headaches, and a lot of them will report non-specific features. They also usually get what's called transient visual obscurations, and these are brief episodes where the vision blacks out in relation to a change in head position, for example, when they bend over. So this is thought to be a result of the pressure shifting around the optic nerve. However, even over half of patients are going to have also pulsatile tinnitus as a symptom. So for another visual symptom, we have diplopia from the abducens nerve palsy, which is, as we mentioned, a non-localizing sign of elevated intracranial pressure. Also, patients can have photopsia, which are flashes of light. So one of the most feared complications of this disease is the sustained or permanent vision loss, but this usually tend to be in cases with aggressive disease course or in patients presenting late. So it happens usually gradually, but of course it can be more of an acute thing sometimes. So for the evaluation, we usually start with MRI with MRV, primary to exclude secondary causes. Nonetheless, there are some abnormalities that can be detected that are suggestive of IH, like flattening of the posterior scleral surface or an empty cella torsica. So after the imaging, we would like to proceed with the lumbar puncture to measure the opening pressure, which is typically high in IH, and remember that the CSF composition should be normal. So an important part in the assessment is the ophthalmological examination, primarily looking for papilledema, and later on, of course, monitoring the disease progression and treatment response. So the diagnosis is commonly based on the modified Dandy criteria. I didn't include it here, but it mentions a lot of what we talked about in the previous slides. So finally, how do we treat? As always, it is crucial to emphasize the non-pharmacological measures. So in this, we have the weight loss, specifically with low sodium diet. Here would also be very helpful. Also, the avoidance of the underlying risk factors, as we mentioned, the medications, hormones, etc. So for the first line medication, it's usually acetazolamide, which belongs to the carbonic anhydrase inhibitors. These will likely decrease the CSF production rates. So for more severe and refractory cases, we could offer procedures and surgical options. So they're usually preserved for the patients with like worsening of the visual symptoms despite medical therapy or more of an aggressive disease. So we can offer serial lumbar punctures, but these just as a temporary solution. There's also optic nerve sheath penetrations. These are basically little cuts in the optic nerve sheath, so just the pressure gets diffused away around the optic nerve. Also, there is CSF shunting, venous stenosis stenting. Okay, so next we have giant cell arteritis. So this is basically an inflammation of medium to large vessels, mainly the extracranial vessels. They can also involve the intracranial vessels as well. So it occurs almost exclusively in patients aged more than 50 and even more typically in the elderly in their late 60s and 70s. Also, they're more common in females and males. So for the risk factors, of course, here we have the age and the gender of being a woman and polymyalgia rheumatica. So around 10 to 15% of patients with polymyalgia rheumatica patients will develop GCA at some point, and approximately half of the patients with GCA, they're linked to the polymyalgia rheumatica. So as for the signs and symptoms, more than 2/3 of the patients are going to present with headache. So the classic headache would be present over the temples. However, it can also be in the frontal area, occipital, or even generalized. And due to the hypoperfusion of the mastication muscles because of the vasculitis, they can also have jaw claudications, crampy pain, and this finding is really specific for GCA. It's also associated with increased likelihood for a positive temporal artery biopsy, which is the confirmatory test for GCA. And so slightly over 1/3 of patients could go completely blind if they left untreated. But the patients also can have systemic symptoms. They could occur up to 1/2 of patients, like fever, fatigue, weight loss. For the diagnostic findings, patients can have tenderness over the palpation of the temporal artery region, or even reduced pulsations. On the labs, typically they're going to have high ESR and CRP levels. And so as we said, for the confirmation of this disease, we're going to have to do a temporal artery biopsy. So whenever you have a high suspicion for GCA, you'd want to start treatment with high dose steroids immediately to avoid the permanent vision loss. However, later on, you're going to have to still confirm the diagnosis to decide further management, as these patients tend to be on a longer duration of steroids, and then also they might take the immunomodulatory therapy. So now we're going to discuss primary headaches. So first we have migraine headaches. So the prevalence rates are 19% for women and 10% for men, and the peak age of onset being from 30 to 39. So just briefly going through the underlying pathogenesis, just to have an idea about it. Basically, there's going to be a release of certain neurotransmitters that are related to pain and inflammation, like substance P and CGRP, that eventually lead to neurogenic inflammation. So basically, they're going to be increased in capillary permeability and vasodilation. That's going to result in the activation of the trigeminal nervous system. So what exactly sets off this cascade is still not completely understood. So generally, there are 5 phases that are acknowledged. They could occur separately or some can overlap. And of course, they differ from one individual to another. But first, we have the prodromal phase. So around 80% of patients will complain of symptoms during this phase, which is during the 48 hours before the onset of the headache or aura. So those symptoms range from some mood changes and irritability to certain food cravings, to even polyuria. They could also have some light sensitivity or neck pain, or even cognitive dysfunction. Then for the second phase, we have aura. Around up to 1/3 of migraine patients, I believe, experience an aura, at least with some of the attacks of the migraine. So auras can be visual, sensory, or they can have motor involvement, language disturbances, or brainstem disturbances. As for the headaches, we're going to talk more about the characteristic a bit more in the next slide. So during the 24 to 48 hours after the headache resolves, we have the postdromal phase. So patients are going to still have some non-headache symptoms like fatigue, difficulty concentrating, even less frequently nausea, some sound and light sensitivity in this phase. Then we're going to have the interictal phase. It's not mentioned here in the illustration. But so this is basically the period of time between the migraine attacks. So despite the fact that patients are largely symptom-free throughout the stage, they frequently still can have some hypersensitivity to lights, sound, and odors, even if they don't have other migraine symptoms. So for the characteristics, it can be summarized in the mnemonic POUND. So the headaches tend to be pulsatile in nature. They extend from hours to days if they're left untreated. They're usually unilateral in location, associated with nausea, vomiting, and they tend to be disabling. Also, they could be associated with phonophobia and photophobia. So here we have a list of the commonest triggers for migraine, but of course, it's always important. So it's important to keep a headache diary and try to identify potential triggers for each patient. So here we have stress on top of the list. Also changes in hormones is another common thing, usually over the menstrual cycle. There's also fasting or missing meals. So not getting enough sleep or changes in sleep pattern is another trigger for migraine. We have certain perfumes or odors, smoke, heat, certain foods, or exercise. So I'm referencing here also the International Classification of Headache Disorder for the diagnostic criteria of migraine. We have the migraine without aura, and also we have the migraine with aura. First, let me double check. Can you still hear me? Or did it disconnect?
Yes, Doctor, we hear you.
Okay, so for the migraine without aura, we're going to have at least 5 or more headaches, lasting from 4 to 72 hours if they're left untreated or unsuccessfully treated. Another criteria is they have to have 2 or more of the following. So it has to be unilateral or pulsating, or of moderate to severe pain. They could also be worsened by routine physical activity. Another criteria is having one or more of the following concomitant symptoms, so nausea, vomiting, or photophobia and phonophobia. And of course, they shouldn't be better accounted for by another diagnosis, as a lot of the secondary headaches can mimic migraines or have similar features. So then with the migraine with aura, we're going to have at least 2 or more migraine attacks with 1 or more of the following aura symptoms. So they could be visual, sensory, speech-related, or some motor dysfunction. They could be of brainstem in nature or retinal. So another criteria is having 3 or more of aura characteristics that is spreads gradually over 5 minutes or more, and 2 or more occur in succession, and each one lasts 5 to 6 minutes, and they should be unilateral in at least one of them and involves a positive symptom. And of course, it shouldn't be justified by another disorder. Okay, as for the management, as always, we should start with the non-pharmacological measures in addition to the medications. So we have here hydration or being in a quiet, dark room would help. As for the medication, this should be individualized based on the severity of the headache. So we can offer non-specific treatments like acetaminophen, NSAIDs, as this works well for some patients. So if we have to step up the treatment, there are some migraine-specific options. Famously, here we have the triptans. So they're considered first-line treatment for moderate to severe migraine attacks. So they're available in different forms. They can come in oral, nasal, subcutaneous injections. So depending on the need of the patient, for example, if the patient is presenting with severe nausea and vomiting, you'd like to choose something that is not given orally. So keep in mind, the thing is with this class of medication, they cause vasoconstriction. So you should avoid it in patients with a history of cerebrovascular disease or cardiovascular disease, so any previous stroke, or even peripheral vascular disease. Okay, so another migraine specific is the triptans. They're CGRP receptor antagonists. This class got approved relatively recently, I believe in 2019. And there is one medication that got approved this year. So when do we start the prevention therapy? So it differs from case to case, of course. So usually when the migraine attacks are frequent, disabling, or hard to treat, or like the patient has contraindications to the abortive management, you could start the prophylaxis therapy. So choosing these suitable medications, once again, dependent on the patient background and preference, but here are some options. There are the antihypertensives. So propranolol is commonly used, but it's contraindicated in patients with asthma, of course, and patients with depression, as it might worsen that. Also, we have the antiepileptics. These are generally teratogenic, so you'd want to avoid them in women in the childbearing age. But we have a topiramate. It's the preferred option in patients who are overweight, as it can lead to weight loss, but it can also cause some cognitive fogginess. Also, we cannot give it to patients with nephrolithiasis or glaucoma.
قفل المايك إذا سمحتوا.
Hello?
ايوه تمام اتفضل.
Okay. So apart from the antiepileptics, we also have the antidepressants. So there is the tricyclic antidepressants, for example, amitriptyline. It's commonly used also. It's good for patients suffering from insomnia, but you're going to have to be aware of the anticholinergic effects of the TCA, as it can cause urinary retention, constipation, dry mouth. They can also precipitate confusion, especially in the elderly, as they're already prone to that. And lastly, here we have the CGRP monoclonal antibodies, which are, so as we mentioned, CGRP is a neuropeptide that is involved in the migraine pathogenesis. Okay, so moving on to the tension headaches. These are actually the most common type of primary headache. with the lifetime prevalence in the general population ranging in different studies between 30% and 78%. They're usually, so those are the headaches that are located bilaterally, and they could be described as band-like, as they're tightly encircling the head. So they're pressing in nature, non-pulsating, but they can be pulsating sometimes. Usually they're mild to moderate in intensity, not incapacitating like migraine. So people could carry on with their daily activities as opposed to migraine. And they're not exacerbated by routine physical activity. So usually they're not accompanied with nausea, vomiting, and patients are far less likely to have any photophobia or phonophobia. So as for the duration, they last from anywhere from 30 minutes to as long as 7 days. So for the diagnostic findings, these can be accompanied by tender muscles in the posterior cervical area, frontal area, or tightness in the posterior neck muscles. Triggers, like most headaches, they could be triggered by stress, anxiety, depression. For the management, NSAIDs work just fine with this type of headache, and they're the mainstay of treatment. So for the prophylactic therapy is mainly prescribed for chronic tension type headache. And here we're talking about headaches occurring for 15 or more days per month for 3 months or more. So amitriptyline here has the strongest evidence. Okay, so now we have the cluster headache. They're very rare headache disorder. They're one of the trigeminal autonomic cephalgias. The prevalence peaks between the ages of 20 to 50. And risk factors include smoking, even just passive smoke exposure or head trauma. Some genetics factors also play in. So they're brief episodes, usually lasting anywhere from 15 minutes to 3 hours, with prominent autonomic features like ptosis, meiosis, lacrimation, periorbital edema, rhinorrhea. They could also have some facial sweating or flushing and oral fullness. They're also accompanied by a sense of restlessness and agitation. So people with cluster headaches get this really severe excruciating pain that is locked to one side of the head, predominantly over the first division of the trigeminal nerve. So mainly periorbital pain or frontal. So also patient can have some light and sound sensitivity as well as nausea. These complaints are far less common than what you usually get with migraines. Also, they tend to have a predictable. I apologize again for the disconnection. Can you hear me now?
Yes, doctor, we hear you now. It's clear.
Okay, so I'll share my screen. So we got to the cluster treatment, or where exactly?
ايوه دكتور، وصلنا عند المانجمنت تبع المايجرين، الكلستر هيديك عفوا.
Okay. Okay, so for the acute management, we usually give the patients 100% oxygen, and it's highly effective in treating cluster headaches. So the mechanism is not really clear, but it may be related to the oxygen-induced vasoconstriction. Also, the oxygen inhibits neuronal activation in the trigeminal nucleus. So subcutaneous injections of triptans also works well. As for the preventive therapy, we have verapamil as an option. It's the actually drug of choice. It's highly effective. It could be prescribed as well as the suboccipital steroid injections. So in summary, depending on the clinical background of the patient, risk factors, associated symptoms, and after careful neurological and relevant examination, you know that you shouldn't also forget the ophthalmological assessment with the neuro exam. So remember here, we're primary want to rule out serious and life-threatening causes of secondary headaches. As we said, the primary headaches tend to be more of a benign process. So guided by that, you can go ahead and order the appropriate investigations. And thank you, of course, for sticking around. I apologize again for the disconnections. I hope you've learned a thing or two from this session. Have a nice day.
تمام، أشكرك يا دكتورة أمل على المحاضرة ويعطيك العافية. إذا في أي أسئلة رجعنا نرسلها في الفيدباك في الرابط اللي اديتكم إياه، ودحين بنرسل لكم رابط إن شاء الله حق التحضير في الشات. أكدوا إنه تحضروا نفسكم قبل ما تطلعوا.
يعطيكم العافية.
شكرا دكتورة على وقتك.
شكرا لكم.